COVID-19 or coronavirus is here. So it's important to have the correct information at hand, like knowing the symptoms: a high temperature, a cough, shortness of breath, or breathing difficulties. If you have symptoms, self-isolate to protect others and phone your GP. Visit hse.ie for updated factual information and advice, or give us a call. Protection from coronavirus. It's in our hands.
Welcome to Our Lady of Lourdes Hospital. I'm going to take you through a virtual tour of your antenatal appointment and what to do when you arrive. Please take time to notice the signage and read them before you proceed. Here we have the front entrance. You may be approaching from the main gate or the side gate. Hand hygiene is of the most importance at this time, so please use the hand sanitizers that are located throughout the hospital. Please proceed through the front doors and carry on under the glass tunnel. After the glass tunnel, please turn left, and this is the entrance to the antenatal clinic. Please be aware of the signage on the floor and on the walls, and this is to protect social distancing. As you move through into the clinic, you will see on the left-hand side attached to the wall there is a hand sanitizer. And please sanitize your hands at these points to protect yourself and our staff. And again, please take time to note the signage and methods that we are using to ensure social distancing. Please proceed then through the next set of double doors. To the left after these doors is the reception desk. Please do not bring any children with you to these appointments. Here there is a secretary who will take your details and register your arrival. You will then be asked to take a seat and wait. So then proceed further on down the corridor to the waiting area. This will be past the midwifery station here on the left, and towards this seating area. Again, please be mindful of the social distancing methods that have been put in place and adhere to them. Please take a seat and wait until you are called by the midwife or the doctor to be seen. Again, I reiterate, you will see that the seats are clearly marked out, so to comply with social distancing. I ask you please to strictly adhere to this to ensure the safety for you and the staff. The bathroom then is located on the right of the waiting area. You will be asked to provide a sample of urine to complete your antenatal assessment. If you do not already have a sample with you, please see that the urine pots can be found on the shelf on the right. And once you have obtained your sample, please then bring it out to the midwife who can test it. The midwife will bring you into this assessment room to obtain your blood pressure. Here she will either take it manually or electronically, decontaminating the equipment. After the blood pressure and the urine assessment has been taken, you will then be asked to take a seat back into the waiting area. Here again, strictly adhering to social distancing, you will wait then to be called by the doctor or the midwife. Once you are called, please proceed to the examination room that the doctor or the midwife is at. Here is an example of one of our rooms. In this room, the doctor or the midwife will perform a private assessment. You will be asked to lie up onto the couch so that we can palpate your uterus and assess the fetal well-being. If further examinations are required, it will be done in this room also. Once your assessment is complete, we ask you to return to the reception or secretary area, so therefore we can schedule your next appointment. If you have any queries or questions, you may ask the midwives at any time or at the desk, but please maintain social distancing at all times. Again, this is to protect you and to protect the staff. Once you have your appointment for the next time, please exit the clinic. Proceed through the double doors, decontaminate your hands with the sanitizer, and turn right to go under the glass tunnel and exit. If you have any symptoms of COVID-19, a high temperature with one or more of the following two symptoms, cough or shortness of breath, please do not attend for your antenatal appointment, but instead please phone 041 98 37 601 and extension 2275, where advice will be given to you over the phone as to what to do next. Thank you for watching this video, and we are here to help during this time. So any questions, please ring us or ask us. We hope to see you soon.
On the 8th of January 2018, Sean came home from school and he was displaying flu-like symptoms. And he said, "I don't feel well, Ma." I said, "Look, you're off tomorrow, have a rest." I gave him a Lemsip that evening and he went to bed. By Tuesday evening, he'd been talking to his sister Zoe and he said, "I don't feel 100%, he said. So on the Wednesday then, he was due back in school and he said to me, "Ma, I feel rotten." I said, "Okay." So I made an appointment for the GP that morning. GP checked him over. She said he has a bad influenza, high fever, chest infection. I'm going to give you an antibiotic in case it progresses to pneumonia. By Thursday, he was getting worse. By this time, Sean had shortness of breath, mottled skin, couldn't sleep, very, very irritable. And I was watching TV with him that night, and about 11:30, he stopped talking to me. And I knew straight away there was something wrong, and Sean stopped breathing. And I called for Joe, and I had to watch Joe give Sean CPR in front of me while I phoned the paramedics. And at 6:30 on Friday the 12th of January, Sean passed away.
So we knew nothing about sepsis. We never even heard of sepsis before they took Sean from us. Sean had no underlying health issues. He was a happy, healthy young man. You know, since then we found out that there's 15,000 reported cases of sepsis per year in Ireland, leading to 3,000 deaths per year.
You know, people ask me what is sepsis, and the easiest way I can explain to them is if you have an infection from anything and it's not getting better and you're displaying any of these signs and symptoms, even two, admit yourself to A&E and your child or your parent or anyone belonging to you and ask them, could it be sepsis?
Thompson and I'm a community midwife at the National Maternity Hospital. I designed and created labour hopscotch in 2015 in response to an increase in the epidural rates and also in medical interventions during labour and birth. The principle of labour hopscotch is to encourage optimal fetal positioning. This means having your baby's head in the optimum position, lined up so it can descend into the pelvis in the optimum position for labour. When this happens, it triggers the spontaneous onset of labour. When women go into spontaneous labour, it's less likely that they'll need induction, and that means that there'll hopefully be less intervention in their births. The labour hopscotch framework aims to support and promote natural and active labour. It is encouraged for all women, regardless of the care pathway that they choose for their birth, but encourages more natural methods of pain relief where possible, for as long as possible in labour. Using the idea of the game hopscotch we all played years ago, each of the steps can be undertaken to remain active during labour. The process can start at home, beginning at the bottom of the hopscotch board when you're more active and mobile. The bottom square of the labour hopscotch is called the mobilised square, and it aims at promoting optimal fetal position. There are 4 activities associated with this step, and it's important that these 4 positions are practiced throughout the antenatal period in preparation for your labour. Your midwife will explain the positions to you during your pregnancy. Our research findings, which we published in 2019 in our research study, showed that women who practiced labour hopscotch had reduced epidural rates, reduced the caesarean section rates, increased spontaneous onset of labour and vaginal deliveries, and most of all, there was an increase in birth satisfaction rates. Having a positive birthing experience makes a smoother transition to parenthood.
So I want to talk a little bit about perineal massage. A perineal massage is something that you can look up yourself on the internet, but ideally from 32-34 weeks gestation, either using the warm water in your bath or using a gentle lubricant such as coconut oil or olive oil, is to use your thumb and first finger. Your perineum is situated between your vagina and your back passage. So gentle pressure between in the perineal body helps to improve the circulation of the perineum, helping it to stretch and to thin during the labour process and helping to minimise perineal trauma. Although you may require to have suturing done post the birth of your baby, the healing process, even with that perineal suturing, can be improved by the utilisation of perineal massage in the antenatal period. So I'm going to start and talk a little bit about optimal fetal positioning. So this is a fancy term really for having your baby into the ideal position for labour and birth. So depending on where you're at in your pregnancy, usually around the 33-34 week mark, we're expecting your baby to move into a head first position. Certainly by 37 weeks, the ideal is that your baby will be in a head down position and ready for engagement for labour and birth. Talk a little bit about the fact that at 30 weeks, your baby may be in a breech position, that is bum first, not head first, and therefore ideally your baby should turn by 37 weeks. If that doesn't happen, don't panic. What we first and foremost do is organise a scan, organise a meeting with your consultant, and a decision will be made then regarding is there a way of getting your baby into an ideal head first position for labour and birth. So optimal fetal positioning is where the baby is already in a head down position, head first position, but is lying with the back of its head, the occiput, facing towards your back or your low back. Okay, you'll often hear this as described as back-to-back position. Okay, we know that coming up to delivery, up to 50% of women, their babies will be in an OP, occipital posterior, on either their left or their right side. And we know that during the labour process itself, most babies will turn so that ultimately they're born facing down as opposed to staying in an OP position where they're born facing upwards. So what can you do to improve your baby's position? First of all, if you're not experiencing backache or discomfort, once you're fit and active and healthy, you don't need to change your position to too much of a degree. What you can do, however, if you're feeling back pain and discomfort and it's associated with an OP position, what you can do is adapt forward facing position. If you have an active ball, fit ball in your house, you can utilise this as an aid to get your baby into an ideal position. What this achieves is a gentle, natural tilt of your pelvis, encouraging your baby to move from an OP to either occipital-lateral or occipital-anterior position on either side. This will ease your back discomfort, leaving your baby in a better position as you approach your due date. Another thing you can do is when you're sitting, either commuting for work, in work, or at home at night, to support your lower back, to put a small cushion in at the small of your back. This straightens the lower part of your back, also encouraging your baby to move that slight move forward that will ease discomfort on your lower back. Also, to improve your baby's position If you don't have a fit ball, you can use a straighter backed chair in your house rather than sitting on the sofa, or if you are sitting on a sofa or a more softer chair, to put that cushion in at the small of your back to reduce the curve at the lower back and encourage your baby into an ideal position. Another thing you can do to improve an OP position is to utilise a door in your house. Once the door handles are sufficiently well applied to the door, to put your feet flat on either side of the door, holding the door handles, and move down into a squatting position. Hold for a couple of seconds and then move backwards. What that is a gentle pelvic lunge and encourages the baby into an ideal position. Another thing you can do as your pregnancy advances, if you have stairs in your house, using the stairs and the banister in your house, whenever you need to go up and down those stairs, to move up and down sideways. Again, that causes a gentle rocking in your pelvis and encourages your baby into an ideal position. So with natural methods of induction, again, it's important to keep fit and active in pregnancy, just as your body is designed to become pregnant and carry your baby to term. There's every reason to believe that it will naturally progress into labour and birth. But these are just hints that may just help that situation of labour to occur. So we will encourage you to utilise post 37 weeks raspberry leaf tea in a tablet or a tea leaf form, which you can get in reputable supermarkets or health food stores. You can also consult with a suitably qualified homeopath, because there is homeopathic remedies that can assist in the onset of labour. So please, if you decide to utilise homeopathic remedies, due speak with a qualified homeopath. Other alternative methods that can assist in the onset of labour is speaking with a reflexologist or an acupuncturist and deciding on a session with either of these alternative therapists. We know that different disorders, minor disorders of pregnancy, such as nausea, vomiting, hemorrhoids, they can all so be remedied by the use of alternative therapy. So it's definitely something worth considering if you go to somebody who is appropriately qualified. Other methods of induction are consider sexual intercourse. Once your waters haven't broken, it's quite safe in the latter stages of pregnancy to utilise sexual intercourse as a way to induce your labour. Old wives' tales, stroke remedies with castor oil or hot baths haven't been proven to be effective and will possibly maybe cause gastric upset, so we wouldn't recommend those. Things we can also recommend here in MLU, or indeed if you're attending the consultant-led clinic, is if you get beyond your due date, we will give you the opportunity to have a vaginal examination with a view to performing a membrane sweep. So what's a membrane sweep? Well, your cervix, the neck of your uterus, sits tucked in right inside your vagina, almost pointing towards your back passage. And it does this to protect your baby against ascending infection during the course of your labour. As you move beyond the 37-week mark, your baby moves down further into the pelvis, beginning to put pressure on the neck of the womb, encouraging it to move forward, begin to thin long before it begins to open. And this is a process known as effacement. And during that process of effacement, you will begin to lose your mucus plug, which is known as issue. If we were to examine you post-term, we would be looking to see where the neck of the womb is positioned. Is it still thick? Is it beginning to thin? Is it partly opened? And if it's partly opened, we will put our gloved finger into the neck of the womb, and with a sweeping motion around the back of around the bag of waters, we're not looking to break them, but that sweeping motion can be sufficient to get that prostaglandin release, which, as I've just mentioned, will hopefully cause a release of oxytocin and stimulate the onset of labour. Now, we can't be guaranteed that it will work. We know that it can work for up to 1 in 8 women. In my experience, you might have 8 women who will do very well from a sweep, and maybe the next 8 who may need to have a second sweep. What we would do is a term plus 4 or 5 would normally offer you a sweep, and then if we're unable to do it, we'll come back and 2 or 3 days later to offer you a repeat opportunity to have a sweep. If you don't wish to have a sweep at term plus 4 or 5, that's perfectly okay. What we'll arrange for you to do is come back at term plus 10, to have an examination at that point, to have a sweep if it's possible, and then we will proceed to book you for medical induction, whereupon you will be admitted to the antenatal ward on the morning of term plus 13, which my colleague on Labour Ward will talk to you a little bit about in a little while. So that's methods of induction.
The first 2 weeks after this child is born, your only job is to eat, sleep, and breastfeed this child. Anything else, any cleaning, any chores, any tending to guests or visitors, falls into someone else's domain. That's not your job. Hi, my name is Dr. Anya Cook. I'm a pediatric resident, and today we're going to talk about everything you need to know on how to breastfeed your baby. I think everybody knows pretty intuitively that if a baby's crying that they're probably hungry, but babies actually give a lot of different signs before they get to the stage where they start crying. So if you look at your baby and they're smacking their lips, their tongue is going in and out of their mouth, they're shaking their head kind of side to side looking for a nipple, and they're grasping and ungrasping their hands, they're actual signs that the baby is hungry. We call them hunger cues. The most important thing is that you're comfortable in the place that you've chosen to breastfeed. So this should be a place that's quiet, that's comfortable, that you really feel okay in. The other thing you want to have is a chair that has a nice amount of back support, and any support devices that you're going to be using, like pillows or blankets, are close to hand. So once you're sitting down with baby, you don't have to get up and get back down. The other thing you might want to do is strip baby down to diaper. This prevents the baby from getting milk drunk. So this is when they get a little bit of milk and they get tired and they fall off the breast too early. If you're a mom and you have to be out with your baby and you have to breastfeed them in public, firstly, you should feel completely empowered to do that. This is what your body is made for. Don't let anybody come into your space and tell you you can't feed your child. There's lots of different little bits of gear that you can get. So there's some things that are more fancy, like certain tops and bras that kind of allow you to be a little bit more covered. But something as simple as a light linen blanket that you can put over your baby so that your boob is covered when you're breastfeeding is also a good idea. You should be feeding your baby kind of as often as they're hungry for it. At that beginning, once breastfeeding has been established, that might be every hour and a half to every 3 hours, right? Once you get to around 2 weeks of life, if baby is able to go longer at night, you can space out your feeds a little bit at night, okay? If they're not waking up and crying. So as you're getting ready to breastfeed your baby, what you can do is strip them down to their diaper, and you can place them, if you're in a position to do it, skin to skin on your chest, and take a little bit of a cuddle break. This is just where you take a second for you and your baby to be alone with each other and have a cuddle. This is great for baby. It helps them bond with you. It helps them get to know your smell. This is great for you because you get a second to actually enjoy your child, and it is absolutely fantastic for your milk production. So once you cuddle your baby, oxytocin is released from your brain. This helps the milk get out of your breast, and it also helps you produce more milk. The most objective way to see if your baby's getting enough milk is following frequently with your pediatrician and seeing if they're gaining weight. When they're small, they should be seeing their pediatrician all the time. So they'll be monitoring their weight gain. The other thing that you can do is look at your baby. After you fed them, do they seem satisfied? Are they falling asleep? Are they going an hour and a half to 3 hours after a feed before they're crying and looking to be fed again? Are they making lots of wet and poopy diapers? If they are, you're probably feeding this child enough milk. When your baby is first born, their stomach is around the size of a marble. It's really, really small. There's only so much milk a stomach that small can hold. And the first breast milk that you produce is called colostrum. It's actually nicknamed liquid gold because it's so dense in nutrition and it's so easily absorbed by a new baby. It's perfectly set up for a child that can only take a small amount of milk. So if your baby is 1 week old and they're making less than 6 wet diapers a day, that probably does mean that they're not getting enough milk, and they should be seen by a pediatrician that day. One of the most common things that moms complain about is pain when they're breastfeeding. And usually that is because their latch, or how the baby fastens onto the breast, isn't right. So for a new mom, it can be really hard to get a sense of how much of my boob should be put into this baby's mouth? How should this look like? Your baby's mouth should be full of nipple and areola. Areola is a pink or darkly pigmented skin around the nipple, and the nipple should be positioned towards the back and roof of the baby's mouth. If the baby is nipple feeding, that's where they only have the nipple at the front of their mouth. It can be firstly really hard for them to get enough milk because they have to work really hard to get the milk out of the boob. And then it also can put a lot of just wear and tear on your nipples and cause you pain. For a mom that is having a lot of nipple discomfort, you have to take care of them. I know that sounds silly. After you've breastfed, get a bit of moist cotton wool, kind of wipe off your nipple, get any debris that's on it off. Letting your nipple air dry protects it from infection because bacteria love moist, wet places, so let it air dry. Then you can get some clean lanolin moisturizer or even some breast milk and drop it on your nipple before you put it back into your bra with a breast shield over it to stop chafing between your nipple and your bra as you go about your day. So if you're a breastfeeding mom, you want to have somewhere between 2,300 to 2,500 calories a day. The diet that you should be having as a breastfeeding mom is kind of the same as any other woman, just a varied, healthy diet. There isn't really any massive food groups that you need to exclude from that. If you are someone that's maybe a little bit more of a picky eater, or if you have a hard time with your veg, it might be a good idea to take a multivitamin. If you're a breastfeeding mom that's a vegetarian or vegan, you probably should be taking a B12 supplement. Yes, you can drink and breastfeed, but you need to be really careful when you're doing it, okay? So if you're having a drink, like 1 standard unit of alcohol, you need to wait at least 2 hours and no less before you breastfeed this child. Pumping and dumping does not work. The only thing that works is waiting 2 hours per 1 unit of alcohol. Can you have coffee when you're breastfeeding? The answer is yes. You just want to make sure that you're applying common sense, that you're not having 10 cups of coffee today and having so much caffeine that it's getting into your breast milk and making your baby irritable. But can you have 1 or 2 cups? Yeah. The CDC advises that a baby should be breastfed exclusively up to 6 months of age, and that's the age where you start introducing food. A lot of other agencies would further advise to partially keep on breastfeeding until the child is 2 years of age. If you are able to do that, great. The majority of mothers that are in America are working mothers that might find it really difficult to keep breastfeeding that long. Really try and get to that 6-month mark if you can. You're protecting your baby when they're not vaccinated against important infections if you keep breastfeeding them up until the 6-month mark. If you can avoid using a bottle on your baby until they're 6 weeks of age, you kind of can avoid something we call nipple confusion. When you're breastfeeding, your nipple sits towards the back and the roof of the baby's mouth, pretty far back. And when you're feeding from a bottle, the teat of the bottle is in the front of the baby's mouth, and they have to work significantly less hard to get that milk out. So what can happen is they're used to this bottle where they don't have to work a lot, and then they go back to the breast and they're like, I don't want to have to do all this work, give me the bottle. If you're pumping your breast milk and then storing the milk for later and feeding in a bottle, you want to look out for a couple of things. One, you want to make sure that your equipment is always clean. You want to make sure that when you're putting your little baggies of breast milk in the fridge, that you're putting a date on them so that they don't end up being stored for too long. No breast milk should be fed to a baby after it's been frozen for 12 months. Not everybody can breastfeed. There are lots of different reasons why a mother will choose to not breastfeed their baby, or sometimes physically won't be able to breastfeed their child. I don't believe in mommy shaming. You are the best thing that your child has, whether you breastfeed or don't breastfeed, okay? So it means nothing about the bond that you have with this child, and it means nothing about you as a mother if you don't breastfeed your baby. The advice that I would give to new moms really is to be kind to yourself, you know? There's just so much pressure now to be a perfect mother and to do everything perfectly all at once. It takes a second. Remember, you just made a person, made this baby, so take some time, rest. This really is time for your body to recoup after a pregnancy. It needs a lot of care and love and rest and food and bonding with baby to make enough milk to feed this child what they need.
Nature has been researching your milk for hundreds of millions of years. The composition of your milk is alive and changes throughout the day, the night, the months, and the years to meet your child's needs. Your milk contains stem cells. These are cells that create and repair the body and are being researched worldwide to cure conditions like Alzheimer's and diabetes. Your milk contains components that kill cancerous cells. Your body identifies bacteria and viruses found in your baby's body and environment. You then produce antibodies specifically tailored to those infections and deliver them to your child through your milk. Your milk appears to switch on a gene in your baby's body, which produces a hormone called leptin. This hormone tells your baby when his tummy is full, protecting him against overeating. Your milk contains oxytocin. a hormone that induces relaxation and feelings of well-being in your child and in you. It's all in you. Human milk, tailor-made for tiny humans.
Changing your newborn's nappy is one of those things you'll be doing 7 or 8 times a day, so it's best to be organised from the start. Make sure you have everything you need ready and close to hand. Place your baby on a clean, soft, flat surface. Open the nappy and wipe away excess stools from the genital area with the corner of the nappy. Hold your baby by the ankles and lift up their bottom. Use soft cotton balls or a wet cloth to clean your baby. Clean around the umbilical cord area. For a girl, be sure to wipe from front to back. This will help minimise the spread of an infection. Swap a clean nappy for the dirty one. Use the tabs to see which way goes up. Avoid covering the umbilical cord as this can cause irritation. For a boy, keep his penis pointed down. Fasten the nappy at both sides with the tapes, making sure it's snug, but not so tight that it pinches the skin. Retape the soiled nappy around the contents, put it in a plastic bag and discard it in the bin. Dress your baby and wash your hands thoroughly. Babies wet their nappies several times a day. The number of wet nappies is a helpful sign of how much fluid the baby is taking in. Generally, a baby should have 5 to 6 wet nappies each day. This is a good indication that they're getting enough milk.